Hi everyone, this is Module 9. This week we're going to be talking about the relationship between blood pressure and hypertension to both physical activity and diet. Last week we talked about cardiovascular disease more generally and also about lipids, and this week I want to specifically focus on hypertension. So blood pressure, there's two numbers that you can look for, the systolic and the diastolic blood pressure. The systolic blood pressure is going to be abbreviated SBP. You'll see that quite a bit in this presentation. This is the highest pressure within the vasculature, and it's generated when the heart contracts. So when the heart actually pumps blood out of the heart to the lungs or to the body, the pressure in the vessels during that time is called the systolic pressure. The diastolic pressure is the lowest pressure. It happens when the heart is relaxing and filling back up with blood. And then there's also the mean arterial pressure. Sometimes you'll see this. It's abbreviated MAP. This is just a weighted average of the systolic and diastolic blood pressure. It's not an average as in where you add the systolic and add the diastolic and divide by 2. It's weighted a little bit differently, but it's an average pressure throughout the vasculature, and so it can be helpful for physicians to understand the mean pressure that your vessels are exposed to. So hypertension, of course, is high blood pressure. Hyper means high or elevated, and this is the classification system for adults. Normal blood pressure is less than 120 over less than 80. That first number 120 that I said, that's the systolic blood pressure. 80 would be the diastolic. And then there's a classification called prehypertension. Someone with a systolic blood pressure from 120 to 139 or a diastolic pressure 80 to 89 would fall in the prehypertensive category. And then to actually be classified as hypertensive, you have to have a systolic blood pressure of at least 140 or a diastolic pressure of 90 or above. So consistent blood pressure of 140 over 90 or higher is also important. Hypertension wouldn't be diagnosed if you went to the doctor one time and you had a blood pressure that met that standard. It would have to be multiple readings on different days. High blood pressure is very problematic because it increases the risk of heart disease, kidney disease, and stroke. And it's particularly dangerous because most people don't know that they have it. There's no warning signs, symptoms, no particular pain or indication that you might have blood pressure problems. So how common is hypertension? That would be the prevalence. There's about 72 million people in the United States who are at least age 20 who have high blood pressure, or that's about 1 in 4 people in the population. And 1/3 of those don't know that they have hypertension. They may not be classified as hypertensive, but less than half of Americans have ideal blood pressure. So that means they may not have that under 120 over 80 that we want. And there are increases in prevalence and severity of hypertension in African Americans, and this is especially concerning because of all of the problems with kidney disease, heart disease, and stroke. So this is from your textbook. This is showing the prevalence in men and women in different racial groups, white, black, and Mexican American. And basically what you see here is that the prevalence in general is between 30 and 35% of hypertension. In whites, the prevalence is a little bit higher in men. In blacks and Mexican Americans, the prevalence is a little bit higher in women. But the overall prevalence is highest in Black Americans, and as I mentioned before, that's especially concerning because there are a lot of adverse health problems associated with hypertension. So finding out why, trying to treat these problems before they get worse is very important. And there's also a geographic difference in hypertension. The lighter the color, the state, the lower the prevalence of hypertension. And you see that hypertension tends to look, this map looks a lot like obesity maps. And not surprisingly, hypertension and obesity are related. So you see a high concentration of states with high prevalence of hypertension in the southeastern United States in particular. High blood pressure is a problem because what it does is it makes the heart work very hard. If there's a lot of pressure in the arteries, the heart has to pump harder to work against that pressure, to ensure that blood is going out of the heart to the body where it needs to be supplied to all the tissues. There's an increased pressure on the walls of the arteries. Arteries take blood away from the heart, and this can actually cause those arteries to get hard and to lose their elasticity or stretchiness. And that makes the heart have to work even harder. So it really is a vicious cycle. Untreated high blood pressure can cause a failure of the heart, kidneys. It can actually cause blindness due to damage to the blood vessels in the eyes. And of course, we know that it's a risk factor for heart disease and for stroke. So untreated hypertension damages 4 organs in particular: the heart, the brain, the kidneys, and then the arteries, which I suppose aren't technically an organ, but the heart, of course, there's risk for heart disease. The brain, there's risk for cerebrovascular disease, which is typically stroke. Kidney disease due to damage of the vessels of the kidneys. And then damage to the large vessels like the aorta. So a common question is, well, what causes hypertension? And unfortunately, there's no simple answer to that. It's a combination of a large number of factors. These include genetic factors. There is a pretty strong genetic contribution to hypertension. Being overweight or obese contributes. Having a diet that is high in salt. What happens is that salt causes water retention, and if you have more water in your body, that would be blood, really. Then if there's more liquid, there's a higher pressure. There's more to move, and so high salt is associated with increased blood pressure. You have narrow or stiffening of the arteries. That could be for a lot of reasons, maybe a diet high in cholesterol, for instance. Aging, the vessels lose elasticity with aging, with or without a healthy diet and exercise, and so aging is associated with elevated blood pressure. Stress, alcohol consumption, and certain disorders. So first I want to just talk about what happens to blood pressure when we exercise. These are good, healthy, normal changes. If we all, you're probably sitting down listening to this or watching it. If you stood up and ran a mile, your blood pressure, your systolic blood pressure would increase. Your diastolic blood pressure would increase very, very slightly or stay the same. And those are normal, healthy responses. Your mean arterial pressure would go up somewhat, but not as much as the systolic blood pressure does. This is what we expect to happen when we exercise. So what about resting blood pressure, though? Can we lower our resting blood pressure by exercising or being physically active? This data is from your textbook based on a study, and it's showing relative risks of hypertension, so being classified as hypertensive in people who perform low amounts of physical activity, moderate, or high, and then it's broken down by men and women. So of course you can see here the reference category is those who do low amounts of physical activity, the relative risk there is 1, and then in men and women, you see a dramatic drop in the other two categories, moderate and high amounts of physical activity. The effect seems to be especially strong in men, at least according to this one study. Relative risk was about 0.6, regardless of whether it was moderate or high. This study is a little bit different. You see people broken down by normotensive here on the left. Normotensive means normal blood pressure. And then prehypertensive, again, their blood pressure would fall between 120 and 139, or 80 and 89 for diastolic. And then those who are actually classified as hypertensive. So if you look at the normotensive, before exercise training and after exercise training, there is not much difference. Same with diastolic. Prehypertensive, same thing. Very little difference before and after exercise training, although there is a decrease. And you see a little bit larger difference before and after training in the hypertensives, from a drop from about 145 millimeters of mercury to about 138 or 9. So a drop of 5-6 millimeters of mercury. So not anything super exciting, and yet probably still important. That physical activity does seem to lower the blood pressure, especially in people who are hypertensive. So I gave you a very brief summary of the research on physical activity and blood pressure. But really, to sum it up, there is a slight lowering of blood pressure with physical activity, but slight is the key word there. And it's been shown repeatedly that the effect is stronger in people who have high blood pressure to start with. In people with a healthy normal blood pressure, physical activity doesn't change blood pressure very much. But in hypertensives, there's a little bit stronger effect. There's a study, the previous slide actually was a meta-analysis. That's a study of a whole bunch of studies on the same topic. And so what this paper did is they looked at a bunch of studies showing the effect of physical activity on blood pressure, and they put those all together to try to calculate an overall effect. And so they found a reduction of 5 millimeters of mercury for systolic blood pressure and 5 millimeters of mercury for diastolic blood pressure in hypertensives, and a reduction of 3 and 2 millimeters of mercury in people who had normal blood pressure. So that just, again, if somebody is hypertensive, there's going to be a little bit stronger effect, but 5 and 7 millimeters of mercury is not particularly, it's a fairly small amount. If somebody's blood pressure is 150 over 90, that might drop them down to 145 over 85, but the magnitude is pretty small. And so that really leads to this question, what about diet? Can we help further or help more by altering diet? You've probably heard that a healthy diet is important for maintaining or reducing blood pressure, and that is true. There's 2 diets in particular that have been studied pretty extensively, and I want to talk about these. These are the Mediterranean diet and the DASH diet. So let's start with the Mediterranean diet. If you think of Mediterranean food, you may think of a lot of olive oil, fish, vegetables, and that is really what you get. So the pyramid, this is not the food pyramid that you might have heard of in elementary school. This is the Mediterranean diet pyramid. So the base of the pyramid is what you eat most. So you eat fruits, vegetables, grains, mostly whole wheat, olive oil, beans, nuts, legumes, seeds, and herbs and spices. So you may think of garlic and basil and some of those. And then fish and seafood is next. You eat a little bit of poultry, eggs, cheese, yogurt, and very little other meats and sweets. And so here's another way to look at it. But again, the emphasis is on fruits, vegetables, grains, beans, nuts, and so forth. So Mediterranean diets may reduce the risk of cardiovascular disease, but due to confounders, there was a need for randomized control trials. So this study was published in 2013. This was a randomized control trial conducted in Spain. The participants had high cardiovascular disease risk, family histories, and so forth, but they had not actually been diagnosed with cardiovascular disease. There were 7,400 and some individuals who were enrolled in the study, and they were all between the ages of 55 and 80. They were assigned to one of three diets: a Mediterranean diet that was supplemented with olive oil, or a Mediterranean diet that was supplemented with nuts, or a control group. And the only intervention, I suppose you would say, in the control group is that they were advised to reduce fat. And so this is these are the results. And so if you look at the primary endpoint, which was heart-related disease, some heart-related incident, a negative incident. The rate in the Mediterranean diet with extra virgin olive oil was 8.1, with the Mediterranean diet with nuts was 8, and then the control diet was 11.2. So these p-values are really small. That means there's a difference in the Mediterranean diet versus the control group. And so basically that means that the Mediterranean diet worked. It did indeed reduce risk. For stroke, you see the same thing. There's a higher risk of stroke here in the control group compared to either this Mediterranean diet group or this Mediterranean diet group. However, if you look at myocardial infarction or death from cardiovascular causes or death from any cause, there was no relationship between the diet and the outcome. So it does seem to have some effect. It's not super strong, it looks like, but there is. This is really showing basically the same thing. You're looking at hazard ratios, which are kind of like odds ratios. A hazard ratio of 0.7 would mean a 30% reduced risk in whatever hazard you're talking about or whatever negative outcome. Basically, you use hazard ratios when the outcome is undesirable. So with a control diet followed over 5 years, you can see that the incidence of cardiovascular disease goes up and up and up because people are getting older. But the line is not as steep with either of the Mediterranean diet groups. So that means there's a lower risk of myocardial infarction, stroke, or death due to cardiovascular disease for those on the Mediterranean diet. Next, let's talk about the DASH diet. DASH stands for Dietary Approaches to Stop Hypertension. So you can see in this cartoon, I guess it is, the DASH diet recommends 6 to 8 servings per day of whole grain, 4 to 5 servings of vegetables, 4 to 5 servings of fruit, and 2 to 3 servings of fat-free or low-fat dairy, 4 to 5 servings per week of nuts, seeds, and legumes, less than 6 servings per day of lean meat, poultry, and fish, less than 5 servings per week of sweets, and 2 to 3 servings per day of fats and oils, but they recommend healthy fats and oils. So basically the DASH diet tells you to reduce sodium, fat, and alcohol. Those are the things they want you to reduce. And in turn increase potassium, calcium, and magnesium. So let's talk about those individually. Potassium, in clinical trials, there is shown to be a relationship between increased potassium and lower blood pressure. And there is enough evidence that basically high potassium foods are healthy and related to blood pressure that this claim can be made. The best sources of potassium are fruits and vegetables. Bananas in particular seem to get a reputation for having a lot of potassium, but really any fruits and vegetables. Magnesium, there's evidence that shows high blood pressure is associated with low consumption of magnesium, and it is found primarily in nuts and beans, which are obviously part of the Mediterranean. And then calcium, the American Heart Association says that increasing calcium intake may preferentially lower blood pressure in salt-sensitive people. Basically, that calcium is particularly helpful in certain individuals. But there's also evidence that people who consume low amounts of calcium at baseline, they're going to respond the best. So if you already get a lot of calcium, it's probably not going to affect your blood pressure a lot. If you don't, it might have a bigger increase. And of course, the best sources of calcium are dairy products, cheese, yogurt, milk, and so. So do DASH studies actually work? Do DASH diets actually work? This is a meta-analysis published last year. Remember, a meta-analysis is basically a study of other studies. So if I took 10 studies on DASH diets and cardiovascular disease and studied them all basically as one big study, that's what you're going to see here, the results from a study like that. So the methods, what they did is they only included studies that used a randomized controlled trial design to evaluate DASH diet on cardiovascular disease. They had to look at systolic and diastolic blood pressure in order to be counted. And then what they did is they weighted the studies based on how many people were in the study. So if 20 people were in the study, those findings wouldn't count as much as if 2,000 people were in the study. So here's what you see. Here, this line in the middle is the 0 line. So any box to the left of this line means that particular study showed a decrease in systolic blood pressure with the DASH diet. Any box to the right of that line meant that the DASH diet was associated with an increase. And you can see that all of the boxes are to the left of the line, some further to the left than others. And this black diamond at the bottom is the overall weighted average of these different studies. Remember, they're weighted based on their sample size. You don't have to understand how that works, except that a study with more people and better methods would count more, basically. So what you see here is the DASH diet decreases systolic blood pressure approximately 6 millimeters of mercury. So if your blood pressure is 180, say, then it would drop it to 174, and so on. For diastolic blood pressure, it looks really similar. Almost all of the studies found a reduction in diastolic blood pressure, but the average effect is a reduction of about 3 millimeters of mercury. So if your diastolic blood pressure is 80, it's going to drop it down to 77. So that's, it's something, but it's not a really large number. So in summary, the Mediterranean diet does seem to decrease risk of cardiovascular disease and stroke, and the DASH diet is effective at reducing blood pressure, but the reduction is pretty small. This week, you have a discussion. Remember that the initial posts are due Wednesday at 11:55, and then the comments on at least 2 classmates' posts are due Friday at 11:55. Your quiz is also due Friday night, 11:59 p.m. And then next week, we will have an exam review. This will be held in our classroom on Monday at 1 p.m. And then the exam will be on Wednesday in that same room from 1 to 2:50. Please let me know if you have any questions, and I'll be happy to help. Thanks so much.